Good morning, afternoon, or evening, depending on where you are. I'm Professor Stephen Goldstein, and I'm the past president of the International Menopause Society, and I will be the moderator for this webinar. I want to tell you that this webinar has been supported by an unrestricted educational grant from Besant Healthcare. Besant Healthcare had no role in the selection of topics or speakers, and has not vetted or reviewed the content of the speaker's presentations. Next slide. And so today's topic is known as the perimenopausal journey, an adaptive reproductive phase. Our first speaker, Professor Nanette Santoro, unfortunately will not be able to be with us in person, but Dr. Santoro has very graciously pre-recorded her lecture. Dr. Nanette Santoro is the E. Stewart Taylor Chairman of Obstetrics and Gynecology at the University of Colorado School of Medicine in Denver, Colorado in the USA, where she's served for the past 15 years. She has been continuously funded by the NIH in the States since 1989 for her research in female reproduction. Her work has covered the processes of pubertal and menopausal transitions, as well as clinical trials in reproduction and menopause. She has held numerous leadership positions in local and national organizations. She's the immediate past president of the Society of Reproductive Investigation. And in 2018, Dr. Santoro was elected to the very prestigious National Academy of Medicine. And with that, I'm going to ask them to play the pre-recording of Dr. Santoro's lecture.
Good day. I'm Nanette Santoro, professor and E. Stewart Taylor Chair of Obstetrics and Gynecology at the University of Colorado School of Medicine. And this presentation is about understanding the perimenopause journey. These are my disclosures. And the learning objectives for this part of the talk or this session is to really discuss the physiologic changes that occur across the menopause transition, to associate these reproductive milestones with changes in aging and other risks for disease, and to review the common and some of the less common symptoms associated with the transition. So first of all, menopause happens against a backdrop of aging, and there's ovarian aging and there's somatic aging. And there's some new data that I want to share that really helps us put some of this into perspective, because we always think of aging as being this continuous process that's moving along somewhat linearly, but recent data suggests that that is not the case. So a recent study in Nature Aging, which I think is very important and helps inform the whole menopause dialogue, looked at multi-omics, so proteins, microbiome, simple lab tests, and looked at how these profiles changed over human aging by doing multiple studies of people over time. And what they found was that there were several inflection points where aging seemed to leap up. So not unlike menopause, which is also kind of a variable but saccadic type of process that moves in bursts, so does the process of somatic aging. And I think this is very important to keep in mind. What they found was that there were transition points in aging in both men and women, and they were not trackable to menopause per se. So just to review it, what they did a little bit, it was 108 people. They were aged 25 to 75. They followed the participants for a maximum of almost 7 years, and they found dysregulation at these two age points, 44 and around age 60. They looked at the markers that you see below: cardiovascular, lipid, alcohol metabolism. These are the things that change in the 40s. This is important because we also see changes associated with menopause at this age range as well, especially if menopause is early. And at 60, the changes were more along the lines of immune regulation and carbohydrate metabolism. So what you can see here, and this is looking at both men and women, these are the significant molecules and microbes that they saw change. And here's the two crests. They're pretty clear at ages 45 and 60. So I think what this really brings home, and you can see on this top graph uh, with the different values and cutoffs that they used, these are very robust. And this shows you the types of measurements. So looking at proteomics, transcriptomics, metabolomics, cytokines, clinical lab tests, simple things like a CBC or a metabolic profile, lipids, microbiome, changes. They are very, very well replicated. I think this is very important to keep in mind as a clinician because we're living in an era where there's a lot of attention on menopause. Not everything is about menopause. So now let's get back to menopause and talk about the different stages. So there are two stages that you really can define, and we really sadly have not done much better than being able to define them using menstrual-based criteria. So prior to the menopause transition, women have what we consider normal ovarian reserve, which is in a fairly wide range because follicles are being lost throughout life. But they reach a certain threshold in the early transition where most often a woman will notice that she skipped a cycle. More cycle irregularity is also a harbinger of the early transition. So for women who use things like my Apple Watch to track their cycles, changes of more than 7 days also herald entry into the early transition. But for most women at a median age of 47, they will skip a cycle. When menses become more far apart, 60 to 364 days apart, that marks the entry into the late menopause transition. And what you can see here is a speed bump, because this transition, which happens at around age 49, is when more symptoms seem to occur. Symptoms begin in the early transition, but for the most part, a woman is being exposed to hormones on a fairly regular basis. There's only a few lapses. By the late transition, there are some changes that really result in more prolonged low estrogen, progesterone, and that's when symptoms kick up. So what's the sequence of events? Ovarian reserve gets low. This is completely clinically silent. Women continue to cycle, but we know that they have less AMH over time. The follicle cohort is smaller. They have less inhibin B, and the follicles that they have make less inhibin A. All of these things restrain FSH. So this lack of restraint on FSH when the ovary can still respond makes cycles happen faster. FSH is pushing that cycle. Those follicles grow. Follicular phases are shorter, and sometimes follicles begin to grow even before the next menstrual period. So we tend to think FSH is high when estrogen is low, but in the early transition, this is more a property of the protein hormones in the ovary. So these early changes will often give women more frequent menses, longer luteal phases relative to the follicular phase, so they may get more prolonged premenstrual symptoms if they have them. And we see evidence that sometimes there are much wider hormone excursions than in mid-reproductive life, so that women that have conditions such as migraine or pre-existing conditions that were tolerable in mid-reproductive life when they were happening every 4 weeks, now if they're happening every 3 weeks, this begins to become bothersome and troublesome. By the late transition, cycles are stretching out. Estrogen is lower more than it is high, and anovulatory cycles seem to happen more frequently. So this is the speed bump where symptoms really accelerate. So even though they may start in the early transition, they're likely to get worse. So what changes in midlife are linked to menopause, and do they influence long-term health? Here, I'm going to rely heavily on data from SWAN, also some from the Penn Ovarian Aging Study, but the SWAN study has given us a great deal of information about a fairly large sample of women from multiple racial and ethnic groups. So we enrolled women from 7 sites, and this began in 1996. Women were 42 to 52 years old at the time. They needed to be defined as being regularly cycling, so still in that pre-stage or in the early transition stage. They were not later than that. So they had to have at least a period within the past 3 months, no hormones, not pregnant, and to have a uterus and at least 1 ovary so that we could track bleeding. We recruited a sample of white women, you can see on the bottom, from all 7 sites, Black women from 4 different sites around the country. And this is important because the Black women in SWAN really have a variety of social determinants of health. These populations are all a little bit different from each other. UCLA recruited Japanese American women, UC Davis recruited Chinese women, and New Jersey recruited Hispanic women, which were mostly Caribbean, South American, Central American, but not Mexican. What we see is that cardiometabolic disease risk markers change acutely during the menopause transition. And the only way you can really line this up, taking into context what I showed you before about aging, is by lining everything up to that final menstrual period. And that really helped in SWAN to clarify what was going on. So I'm going to show you a series of graphs that look at a bunch of biological markers, and you can see this is 0, the final menstrual period. When things change here, you can pretty much assume that that is because this is related to menopause. So when you look at the incidence of metabolic syndrome, it's fairly low and it's creeping along at a low rate. That's moving along this lower red line. After the final menstrual period, there's a pretty marked change in the slope of this line. And this implies that menopause itself puts women at higher risk. Now, some of this may be due to some of the omics data that we saw before, that around age 45, women do get a little bit of a higher risk here. So they may be contributing, but this inflection being so closely linked to the final menstrual period strongly implies that menopause itself is playing a role. Abdominal visceral fat accelerates in the perimenopause. And this is 2 years before the final menstrual period, up to the final menstrual period. You can see there's a marked increase in the rate of accrual. This is before hormones completely drop out of the picture. So again, it implies it isn't just about estrogen, but there's something about menopause and perhaps even the stress of the transition itself that bumps up this accumulation of visceral fat. After menopause is over, it goes back to a more benign curve. It's increasing, but not as quickly, but also not as slowly as it was in those premenopausal years. When we look at carotid artery intimal medial thickness, a measurement of plaque, we also see that premenopause, that's pretty flat. In the perimenopause, it goes up more steeply, and in the postmenopause, it continues to go up, but again, it assumes a more benign curve. And we have that blip. So you can see this here shown graphically, how it accelerates. So premenopause, early perimenopause, when estrogen is not really dropping out that much, no big change. The late perimenopause, that speed bump for symptoms, is also a speed bump for plaque. And then notice how much it goes down afterwards. So there is something about the transition itself that makes this change. Similarly, other markers like carotid femoral pulse wave velocity, that's a measure of arterial stiffness, fairly flat premenopause. In those years surrounding menopause, it bumps up, and then after menopause, it flattens out again. LDL cholesterol rises very steeply, and this seems to be rather dramatic across the transition, and then flattens out again. Abdominal fat, some of this fat is not all visceral abdominal fat, it is subcutaneous fat. So what we saw really most markedly in SWAN was that there was a small change in BMI overall when you look at the whole population, but there is an exchange of fat to lean. So here's the proportion of fat going up, lean goes down a bit, restabilizes again 1 to 2 years after menopause is over, after the final menstrual period, but there is this net increase in fat mass that occurs. And similarly in SWAN, we see changes associated with menopause and bone density. And this has really led to an understanding of the transmenopause as being a point in life where women lose a substantial part of their skeleton, 6 to 7% over this 4 to 5 year period of time. And again, the final menstrual period, bone loss pretty stable, then it drops, then it levels off again. So here you can see the premenopause in red, early perimenopause, no real change in bone density. So if you are looking for estrogen-related changes in bone density, don't bother looking until you're in the late perimenopause, in that late transition, 60 to 364 days of amenorrhea. Now, unlike other issues, bone loss will decrease. It doesn't go right back to baseline, but it does decelerate. So what kinds of symptoms do we see across the transition? What's due to perimenopause, menopause, and what is not? Now, the classic symptoms are what I call the core four. Vasomotor symptoms are reported by most population studies report around 80–85% of women will note them. Most of the time they are moderate to severe. Few women report mild ones. Vaginal dryness and dyspareunia, it depends on exactly how you ask this question, is reported, and this is more postmenopausal than perimenopausal, in a quarter to up to more than 3/4 of women. Depression, anxiety, irritability, and mood swings, about 20–30% of women, we know depressive symptoms go up, again, worst in the late transition, but they can persist. And worsening sleep is reported by a sizable portion of women, almost half. Now, there are some atypical menopause symptoms. Joint pain is one. We do know this seems to be related to estrogen because of women who take aromatase inhibitors will sometimes develop pain. And palpitations also are reported by a certain percentage, about 3–5% of women across the menopause transition. And there are others. And your patient may have her own symptom that doesn't seem to make sense, but that may be related. So vasomotor symptoms, when they were looked at longitudinally in SWAN, we saw that they lasted longer than we had previously thought. So the median duration is about 7.5 years. And some women have much longer durations. So this is a series of life table Kaplan-Meier curves showing when they appear on the left. And you can see if they started when you were premenopausal, 10 years later, 75% of those women were still having hot flashes. So these may be the ones who are what I call sort of the lifers, who may require treatment for very long periods of time. If they don't appear until after you're postmenopausal, it's a much different story. And by 4 years, those people have crossed the 50% threshold. So less than half are having hot flashes then. And by 10 years, only 20% are still reporting hot flashes. For women who they appear in the early transition and the late transition, there's a difference. So the late transition people really follow more of that postmenopausal curve, which is fairly benign. But if they appear early, they're going to last for a long time. And the green line just shows the median, which is about that 7.4 years. When we looked by race ethnicity, and this is self-reported race ethnicity, so these women just reported themselves. We did not do any genetic testing or anything to confirm. So this is more of a social construct of race and ethnicity. African-American women in SWAN were the biggest flashers. Their median duration was around 10+ years, very similar to the pan-ovarian aging study, which found that African-American women had hot flashes for about 11.5 years. Hispanic women were a little bit less than the African-American women. White women shown in orange here, kind of in the middle. And the Japanese and Chinese cohorts in SWAN had the least long duration of hot flashes. So they were again in that 5-year range for median duration. And the green line just shows the curve for all of the participants. So we used to think that hot flashes were benign and they were transient and they were no big deal in terms of long-term health, but investigators like Rebecca Thurston are now showing that if you are a hot flasher with the more frequent hot flashes, and that's shown in red here, the high flashers, and also the women with early onset shown in purple here, you have higher cardiovascular risk. So the left side graph shows you carotid intimal medial thickness, measurement of plaque, higher in those women, highest in the women with early onset, and those with a high frequency. So if your vasomotor symptom trajectory is early or frequent, this puts you at a higher risk later in life. So this is actual cardiovascular events 20 years later, because SWAN has now been in operation that long, so we're able to track the population. There is a substantial difference in CVD events in the women that had the worst hot flashes. Other symptoms that are important is that depressive symptoms, almost 30% of women in SWAN reported an increase in depressive symptoms, and these peak in the late transition, again, that hot spot for symptoms, and start to subside. We saw some evidence that hormone therapy users had a reduction in their vulnerability to depressive symptoms. We also saw that the risk of major depression, as did a couple of other studies done at the same time, goes up in the menopause transition, and particularly in that late transition. Sleep is also disrupted in relation to menopause, although it is debatable how much of this is age-related. And there is a gender discrepancy, sex discrepancy in sleep. Women report more sleep problems overall than men, and they do tend to get worse. But these are sleep trajectories that have been looked at in SWAN. And this is the percent of women that are reporting waking up at night, because we now know that this is a harbinger of potential future health problems. The women who were doing very well before the final menstrual period and who really ramp up, along with those who always have poor sleep, seem to be related to race and ethnicity, as well as to other health outcomes such as metabolic syndrome and weight gain. Black and white women were more likely to experience this curve of that increased waking after sleep compared to other racial and ethnic groups. But overall, Black and Hispanic women seem to have shorter sleep and lower sleep efficiency, and we know these things have consequences for later life health. We have also noted in SWAN that midlife women with multiple physical and mental health symptoms are at higher risk for diseases that we tend to think of as being related to chronic stress, metabolic syndrome, and diabetes. So these are the latent symptom classes that we see in SWAN. And the women that remained free of diabetes with the worst latent symptom class are the ones these are the ones with high intensity symptoms. You can see that fewer of these women were free of diabetes, fewer of those women were free of metabolic syndrome. So it's another sign to clinicians to pay attention to these symptoms and their severity, because they have meaning for future health. They need to be addressed. So summary and takeaways are that the menopause transition is an adaptive challenge for women. It involves instability of hormones, as well as changes in a wide number of physiologic variables. And we are beginning to be able to wrap our heads around how that translates into later life health. Individual vulnerabilities, which may be genetic, may be environmental, may be related to social determinants of health, all seem to influence the menopause experience. And rather than think of these symptoms as temporary, inconvenient, but benign, they may well be harbingers of future disease risk. So as clinicians, we need to pay attention to that. And with that, I thank you for your attention.
Thank you very much to Dr. Santoro, even though she's not hearing us. Thank her. Excellent overview. I want to remind you that if you have questions, please, there's a Q&A button at the bottom of the screen. Please enter your questions in the Q&A button, and certainly at the end of the next presentation, Professor Nappi and I will do our best to answer all of your questions, including those that might have been posed to Dr. Santoro. Our next speaker, I know it's a worn-out phrase, but clearly needs no introduction. Professor Rossella Nappi. Her major interests are psychological neuroendocrinology of female reproductive and post-reproductive life, with a special focus on women's sexual health. Professor Nappi has published around 350 scientific articles in peer-reviewed journals and international books, with maybe 17,500 citations, according to Google Scholar. She is a well-known speaker on women's health from adolescence to menopause. She's been very active in many international meetings and research projects in the field of contraception, in the field of menopause, female sexual dysfunction. She's a past president of ISWICH, the International Society of the Study of Women's Sexual Health. And at present, she's a permanent member of the advisory board of the ISGE, the International Society of Gynecologic Endocrinology, and the Human Academy of Reproduction, HAR. And most importantly, she is currently the president of the International Menopause Society, the IMS, the sponsor of today's webinar with the help of the SANS. Her title is Perimenopause and the Use of MHT. And with that, I turn the podium over to Professor Nappi.
Thank you, Stephen, and hello to everybody. It's a real pleasure always to be here in the activity we do to share with our colleagues across the world our passion for the menopause. And I will talk about the use of menopause hormone therapy in perimenopause. And I was practically sure that Nanette Santoro, I'm so sorry she couldn't join us live, she was giving you a very fantastic introduction. And this is the reason why I would like to start with one of her best cartoon in order to summarize why we really need to learn to do our best to personalize the treatment for women across the menopausal transition. Because you will agree with me that we always think about the last menstrual bleeding. By the book, we studied that menopause is there and you need to treat women 12 months after the last menstrual bleeding. But we have learned that everything is happening across the menopause at the time of perimenopause. And if you are an OBGYN, of course, you see the patient because of menstrual irregularities, and so you are in need of controlling the bleeding. And we have Stephen here, that is one of the major experts in the world on this topic, and we can discuss with him also the way he is trying to control the bleeding across the menopause. But you also need maybe to fulfill some contraceptive needs, even though we know that it's not so easy to be pregnant and to carry a baby when you are older than 45, 46. But we know very well that you can be pregnant and maybe having also so many complications. And last but not least, we have to start preventing the symptoms, but also preventing the diseases, because you have seen very clearly that the link between hot flashes and the menstrual irregularities is very strong in terms of cardiometabolic health. So menopause is a cardiometabolic transition that starts earlier than the final menstrual period. And you will agree also with me if you follow IMS, North American Menopause Society, and every menopause society in the world, that menopause hormone therapy is the first line treatment to treat vasomotor symptoms, of course, but also all the symptoms overall. But you also know very well that the majority of the drugs we have in our hands, hormone therapy, they were tested, they were registered, they were approved in women post-menopause. And this is the reason why we need to discuss from a practical point of view how we can handle at our best women across the menopausal transition. And if you didn't do already, I think that the best document to help us to navigate across this, it's really the last practitioner's toolkit that was published in our journal Climateric by Susan Davis group, because she summarized in one manuscript all the things we know. And I will comment on this. Let's start by this very simple cartoon. And just to make it clear that we have to consider that perimenopause is there, but we have premenopausal women. So think about that women when they are 40 plus, 45 plus, they are in this period of their life where we still need to answer to the reproductive needs. And therefore, we have to really do a full medical history, also including not only individual person history, but also family history, because this is the time we have to start thinking to the fact that some women, they will change their general health, they will develop some risk factors for the most relevant non-communicable diseases. Also, we have to pay attention very much when we prescribe any kind of hormones, starting with contraceptive hormones that they can precede the traditional menopause hormone therapy we are used to discuss in our menopause meeting. But these women, they can have a healthy lifestyle, but also an healthy lifestyle. And we have to work on that, because the prescription for contraception has to take into consideration these aspects, not only menopause hormone therapy, but also contraceptive hormones that can behave as, let's say, a primordial form of menopause hormone therapy, because you will agree with me that we can do the menopausal transition by selecting the appropriate contraceptive hormones. And when indeed we look at the most important guidelines that we have out there for eligibility criteria, and I just took this cartoon from the US, not because I don't want to be in the world, but because this was very, very much clear in my view. You see that when you are a woman 40 plus, you can use any kind of combined hormonal contraception according to the criteria, and the benefit overcome the risk. But of course, it's better to personalize this choice. And nowadays, when we have to deal with combined hormonal contraception, we may consider very, very low dose, for example, of ethinyl estradiol pill. We can use also, according to the different countries in the world, if they are available, the vaginal contraceptive option. But most importantly, we can use natural estrogen, both estradiol valerate and estradiol, but also in some countries, the new pill containing estetrol, a specific natural estrogen, because they are more physiological if you think about it. They are more useful to those women that develop some kind of risk. But we have to consider also that we have to include progestogen only pill, especially for those patients that are high risk because they are already obese, they smoke more than 10 cigarettes a day, even though we have to advise them to stop, but in some cases it's difficult. And also we have people, they already have some kind of disorders. Think about diabetes, think about hypertension, in which maybe we want to avoid the use of hormones. Keeping in mind, however, that depending on the stage of the transition, some women, they can develop the symptoms because maybe the estradiol goes down. Whereas when the women, they are cross the menopause, but they still have enough estrogen, maybe progestogen only pill, IUD or implants can be enough. And as you know very well, we don't have a specific rule to say when is the time I have to switch from contraceptive option to a menopause hormone therapy. And according to the different societies, we may have different suggestions. My personal ideas is really that you are not wrong if maybe you go across the last, let's say 50, 51, 52 with a natural contraceptive hormone pill, because in some way you are replacing the hormones. Whereas when you are using a POP option, you will learn from the patient when is the right time, because when women, they stop having feeling good and they start feeling, for example, vaginal dryness, vasomotor symptoms, etc., or develop other symptoms, you will understand that it's time to switch. In any case, we can discuss together what's your best method at the end of my talk. This is a cartoon, very simple, that summarizes what we have said, that we can believe that is appropriate to use for tolerability and safety natural contraceptive estrogen pill, also because apart from contraception, we can regulate the menstrual cycle, we can prevent the irregular menstrual bleeding. In some way, we can treat the symptom, but keep in mind that we can do also a very important protection of the bone, because we have seen in the literature that menstrual irregularities at this time, they can cause a decline of the bone mineral density that can start already before the last menstrual period. And of course, we can obtain oncological protection in terms of ovarian, endometrium, and even colorectal cancer. And most importantly, we can prevent endometrial hyperplasia. On the other way around, the progestogen-only contraception is good, but keep in mind, no BMD protection and no protection from vasomotor symptoms. According to some practical rule, and also according to the toolkit of Susan Davis, we may add natural estradiol, but this is off-label. We can do with a POP, we can do with an implant, we can do with IUD containing levonorgestrel, because this is the best way, if you think about, especially when you have to protect the endometrium, to counteract on one end the irregular cycle, and on the other hand, to start introducing some little amount of estrogen to control the hot flashes. Why is so important to use natural estrogen? Because of the safety. You have seen without any doubt that across the transition we have an increase of some cardiovascular and metabolic risk factors. And also, if this table is very busy, I want to show it to you because it's very precise, and there is a significant comparison, very well done by Franz Stachnik on contraception, on the property of estradiol and estetrol. This new option we have in contraception, they are very important in terms of thromboembolism, of thromboembolic risk, homeostasis, and also you have a reduction in the amount of the bleeding. Of course, I know that across the world, still ethinyl estradiol containing pills are used, but please keep in mind really to go lower in this category of patient, especially if they have some risk factors. What's about the progestogen? We know that we use a lot also progestogen across the menopausal transition to control the bleeding. However, we don't have so many progestogens that we can use alone to control the bleeding. According to different countries, we have different availability. In my country, I'm sure, for example, that you can use medroxyprogesterone acetate alone to control the bleeding, or, of course, to start building up an individualized menopause hormone therapy that you can do using little amount of estrogen if you want to offer a customization of the treatment. Otherwise, of course, we can use traditional menopause hormone therapy, but we use medroxyprogesterone acetate usually with transdermal route. We don't have availability anymore of conjugated equine estrogen. You may use some progestogen for contraception alone, and there are some progestogen, they are very flexible depending on the market, because you can use both for contraception and therefore you can switch to menopause hormone therapy. This is the case, for example, think about for normegestrel acetate, especially in Europe, in Latin America, for Dienogest or for drospirenol. very interestingly, is the fact that we can use for controlling the endometrium dihydrogesterone, for example, alone, and for menopause hormone therapy, a different dosage in different ways. But not all the treatment, we will see in a minute, they are very useful during the menopausal transition, because the best way to go across the transition is really to try to control the bleeding. And when we use menopause hormone therapy, continuous combined, it's much more difficult to control the bleeding, and it's much better to propose combine hormonal treatment, because in this way you shut down the residual ovarian function that can complicate your life. But in any case, we have plenty of opportunity. So if we want to summarize this part, really I like to share this table that is very simple, and what this table bring to you, that we can try to build up a treatment if we have some problem with the traditional one. We can use the COC, we can use the levonorgestrel IUD with some amount of continuous estrogen. We can even combine continuous estrogen with cyclical progestogen, depending if we want to achieve contraceptive benefits or not. But keep in mind that we have to use some practical tricks sometime, and we can really use now the two different POP we have on the market to go throughout the transition and to try to provide contraception and bleeding control, both with the desogestrel POP or even with the drospirenone POP that we have on the market. Why? Because this drospirenone POP, we have also some products for the postmenopause, and this can be good because you go into continuity. I can add, for example, that you can use the Dienogest alone, maybe in women that have particular difficult uterus. Think about fibromatosis, think about women with adenomyosis, and then you can add little amount of estradiol. This was not included in the table from Susan Davis, but it can be done. But then we move to the more traditional concept of menopause hormone therapy, and it's very important. I share with you the white paper we wrote with all the colleagues from IMS last October, and be ready also for the new guidelines this year that will come out, we hope, in the issue in August in Climateric. We summarize in a colloquial way what we know nowadays about menopause hormone therapy. And I'm sure you are aware of our 5 W's. And I will just focus your attention on the first 2. Who are the women? They are good candidates for menopause hormone therapy, and elaborating a little bit more on the type and the dose of the menopause hormone therapy, focusing our attention, of course, on the perimenopausal transition. I'm sure you know the indication. We said already, distressing symptoms, vulvovaginal atrophy, genitourinary syndrome of menopause. Think about that osteoporosis prevention is very important. In some countries is second line, such as in mine. In some other is first line. But we really need to treat women that are symptomatic, and we really need to treat for symptoms of the menopause. We don't have to consider this treatment as an elixir of youth, because you have seen from Nanette that there are also some genes that has to do with aging. And in this context, maybe almost they cannot do all the job because we are aging, both men and women. And this is a very important point that we have to consider, because otherwise we don't work according to evidence-based practice. We have to consider that some women, they can enter the menopause early, and therefore they can enter menopause transition early. Keep in mind that for these women, we really still are not sure if it's better to propose contraceptive hormones or menopause hormone therapy. There is a very important study that is underway to try to prove the point if it's better to use a combined hormonal contraception, because if you think about with combined hormonal contraception, we prescribe more hormones, and we know that maybe younger women, they need higher dose of estrogen, and we don't have so many traditional, let's say, menopause hormone therapy for this category of women, because following the WHI, as you know very well, we went lower with the dosage. We realized that when we can treat women with lower dose, but unfortunately, younger women, they may need higher. We will have this answer, we hope soon, what is best for women entering the menopausal transition early. But there is absolutely no doubt that these women, they have to be treated even though they don't have significant symptoms, because really they are early estrogen deprived women. They can still ovulate, and this is the reason why maybe contraceptive hormones they can be useful. Always remember the high risk concept I already told you. This is true for contraception, but this is true also for menopause hormone therapy. And this is the reason why it's very important to discuss a little bit more why the type of estrogen is important, even for menopause hormone therapy, not only for contraception, and thinking about if the type of progestogen may be important. Keeping in mind, however, that we don't have so many comparative studies saying that one is better than another, especially in this category of women. So sometimes, if there are not very clear contraindication, as I told you, diabetes, hypertension are the very important risk factor in terms of vascular risk. Think about migraine with aura, for example, or maybe thrombophilic condition, etc., etc., etc. We have to consider always the patient preference, and keeping in mind that if you don't have the uterus, of course, you are lucky and you can use only estrogen alone, and maybe we should tailor some treatment according to symptom type and severity, because we know, for example, that in some women, to prevent the so-called progestogen withdrawal symptom, maybe it's better to use one treatment or another. We can have into the discussion. For sure, what we know that estradiol is not similar to EE, that is a synthetic estrogen, is much more similar in some way to conjugate equine estrogen, because they are natural estrogen. Because sometimes I hear from my students that conjugated equine estrogen, they are not natural. They are natural. The problem is, maybe is they have some components they are not found in the woman body, because they are metabolites, and these metabolites in some way they can have their own peculiarities on women health. So it's a much more complex compound in comparison to natural estradiol, but of course it can be used. The problem is that following WHI, in some countries we don't have these compounds anymore, and we have only a combination with a SERM that is basedoxetan, that is much more useful in the postmenopause instead of the perimenopause, because we don't have so many data. What is the meaning of giving this drug when some kind of endogenous activity is already there? And this is the reason why I propose to you the cartoon that Susan Davis and her group published on menopause hormone therapy. And we will try to discuss what is happening during the transition. Of course, during the transition, you have to think about that having maybe some endogenous production of estrogen, you really need to start low dose or middle range dose, because you may have some activities already. So it's better to start low dose and then increase. And as I told you already, younger women may need higher dose. And we have some products that can be used orally or transdermally. And keep in mind that with the transdermal route, sometimes you can really titrate the dose and you can really customize your offer, because depending on the product you use, if you use the spray, the pump, you can use 1, 2, 3, etc. And depending on the product, you have a variability in the dose. Keep in mind that usually one pump is around 11, 15 picogram. And therefore you can increase the dose, but we have the safety with 3-4 pumps safety data, not so much more, especially if we have to combine progestogen, as I will show you in a second. So please keep in mind that it's always a balance in terms of safety between what we offer as estrogen and what we offer as progestogen. And this is the reason why sometimes using the oral route may be much more convenient, because you have something that is really standardized, goes orally, and most importantly, you have already in combination with a progestogen that has been proven to protect the endometrium, keep in mind in postmenopause, but maybe not in the perimenopause. And this is the reason why you really need to watch your patient. And this is usually the time period in which scientists and clinicians such as Steve Goldstein, they are useful, because you may use ultrasound to try to figure out if your endometrium is in the safe space or you are still a follicular activity. And it's very important we reinforce with this cartoon the idea that estradiol, both oral and transdermal, is a little bit safer in comparison of thromboembolic risk in comparison to conjugated equine estrogen. And I just select this cartoon because it's one of the more recent we have out there in the literature. And last point of information is really the importance of the progestogen. We said that progestogen is critical to regulate the endometrium, to prevent endometrial hyperplasia and abnormal uterine bleeding. And it's important we know that, because we don't want to cause bleeding to the woman, but during the perimenopause, this is necessary because the progestogen is useful to protect the endometrium. What we can offer to our patient on the majority of the market, I know we have more products. They are sequential, continuous, meaning that we offer estrogen, different doses, for example, for a certain amount of days. In some countries, we may have 12 tablets. They contain progestogen. In other countries, or according to different products, we may have 14. Remember that 12 and 14 tablets of hormones containing progestogen, they are necessary to protect the endometrium. Of course, we can do differently in patients, specific patients in which we believe administering the progestogen can induce some PMS-like symptoms, but we really need to watch our patient. Usually what is in combination is fixed, and when we play, we use the transdermal route, either the patch or the pump. Some market, I'm aware, we can have also sequential cyclic, maybe just 1 week off, exactly as the pill, or 4 days off. But sometimes these women, they suffer from symptoms during this week that is free from hormone, and we really need to replace with some transdermal. So depends on the woman, and this is the reason why we really need to individualize the treatment in this age group when we have the transition. What we have out there, the table of Susan Davis summarized the most common in the market, dihydrogesterone and micronized progesterone. Remember, they are very similar because dihydrogesterone is really very, very similar to progesterone. And depending on the product we use, and depending on the dose of estrogen we use, we can use different amount of progestogen. 10 milligram for the progesterone with mid to high dose, and 5 milligram with low dose of estrogen. Usually we use 200 milligram of micronized progesterone in sequential treatment because lower doses has been studied only when we use continuous combine. So when women, they are already well with their feet in the postmenopausal transition. We can use medroxyprogesterone acetate as well. We can use in some market norethistone acetate, especially in Northern Europe. We can use in the transdermal combined patch norethistone acetate as well. But we don't have very low dose estrogen patch on the market because following WHI, unfortunately, we have only the standard dose. Keep in mind that in some market we can use no magistral acetate, we can use Dienogest, and we can use even cyproterone acetate that is not included in the table by Susan Davis because it's only on few markets in the world. And why the progestogen is so important? We know that it's important to protect the endometrium, but we know also that we have a slight change in the risk for breast cancer. But these slight change, they are extremely important, and I absolutely agree with this cartoon that was produced and with our friend from France and from market in which the progesterone is so much used, because we know that these are the products which they are less invasive, let's say, on the risk of breast cancer. But keep in mind that some women, they are okay with maybe other product because of their mood, well-being, sexual function, and therefore we really need to individualize the treatment, because you agree with me that this mild risk we see on breast cancer, it's really over time, and therefore if some women, they need for their well-being, especially in the transition, a specific progesterone in comparison to another, I don't think we have to consider one progestogen a devil, one other progesterone an angel. We really need to try to fix our patient. And this is really my personal point of view, but it's really what we have out there in the literature, that across the transition, we really need to individualize our choices, because what is very, very important is to help our patient to go throughout this difficult moment there in their life. And I start inviting everybody, even though if we are almost 2 years in advance, to Rio de Janeiro. Thanks a lot for your attention, and I hope you enjoy this perspective, that it was less research and more clinical practice.
Thank you very much, Rossella. That was outstanding. And we have a number, I guess, of questions in our Q&A file. Maybe before we get to that, and I'm really sorry that Nanette's not here to field some of these questions. You and I will have to do the best that we can. I was really gratified to hear, you reiterate something that many of us have said. A trend that I have noticed is that many people who are new to this field, the membership of the Menopause Society in the States almost doubled in 1 year, are treating a large number of perimenopausal women with an estradiol patch and some prometrium or a Mirena IUD. And although that may help some of the vasomotor symptoms, it doesn't help the bleeding. And I think you were very, very clear, and I heard the message loud and clear, that if it's not contraindicated, hormonal cycle control, i.e. birth control pills in the lowest dose, would always be the preferred method, as far as I can understand, to treat such women, unless there's a contraindication.
Sure, Stephen, especially the one, I may say, with difficult uterus and unpredictable ovaries, because, we have learned over the years of our practice that women, they are so diverse, and the diversity is especially present in the perimenopause, in the way women, they they go across this passage in their life, because some women, have just few bleeding, they have already so many symptoms. Other, they have an alternation of, breast tenderness and bloating, etc. So a huge amount of estradiol, and other moment in which they are so low and therefore they develop migraine, headache, etc. So when you're lucky enough to have natural estrogen pill, this is the best way, because you stabilize the gonad. It takes maybe a while. Sometimes it's not enough because you still see some follicles in there, because it's not so strong, the inhibition you have in the ovary. But over 3-6 months, you will achieve a good endometrial and ovarian protection in terms of oncological disorder, and sometimes you will relieve the symptom because you are prescribing estrogen, so a replacement, but nobody think about that. And so this is very important, and I think this is the best way. But if you have maybe endometriosis or adenomyosis, even IUD can be okay, but you really need to combine with the right amount of estrogen. Keeping in mind, however, that you don't have to play too much, because we really need to go and in terms of safety, because I believe when you are in this period in your life, hyperplasia can be there, and so IUD is good. But if you use just a little amount of progestogen, or what I heard, a progesterone cream, please be careful, because bioidentical hormones need to be studied properly in order to say that they are effective in protecting the endometrium. Sorry, but I don't like that.
I also think that many patients, at least in my clinic, when you suggest the use of very low dose birth control methods, whether they're low dose pills, patches, rings, to suppress erratic ovarian function. In other words, this is not on top of what they're making. This suppresses endogenous ovarian function, becomes instead of what they're making. There are a lot of myths that are associated with this. We've known about cancer reduction from suppressing ovarian function for more than 25 years, and yet many women believe that the use of such pills or hormonal cycle suppression is going to increase their risk of cancer, which it doesn't. Many people think this isn't natural. It's not natural to have 500 menstrual cycles. We're higher order primates. There's a lot of work, I think, that needs to be done.
Yeah, you are absolutely right, Stephen. I always think about this topic, and I realize that some women, they come to see me and they say, I don't want to go to that gynecologist, he gave me the pill. But I think we have really to put contraception in the armamentarium. And this is the reason why the toolkit is beautiful, because we put contraception in our armamentarium of menopause hormone therapy. And we have to explain to women this, that because, we always say to women, you cannot have a baby following 45 years of age. So when she entered our office and we propose contraceptive hormones, we really, it's a nonsense in some way for our patient. And this is the reason why we have to cancel. And last but not least, remember that with natural hormones in contraception, now we have increasing data suggesting that you offer a better well-being in terms of mood, sexuality, because when you shut down the ovarian function, of course, you can decrease the androgen, maybe you can decrease the mood. So we really need to play with low ethinyl estradiol combination, because they are good for safety, and with natural estrogen. This is the best way, and you're never wrong.
So I would offer you a suggestion. In my clinic, I've stopped calling this contraception, although we know that it is, but patients that are of that age are usually not very concerned about that they may become pregnant. I've started calling it hormonal cycle control rather than contraceptives. In other words, letting them know that I'm giving this as much to turn off erratic ovarian function and substitute a stable amount of estrogen and progestogen all month long. One other point I want to make before we get to the Q&A, and it has to do with the NK3 receptor antagonists. It would appear that we now understand one, if not the main mechanism for vasomotor symptoms, and it's the removal of estradiol, which allows hypertrophy of this candy neuron. And apparently it takes place very quickly because when you antagonize this, you can get relief sometimes in people in days. So I'm wondering if you would agree that much of the vasomotor symptomatology in perimenopausal women is not the absence of estradiol of menopause, but the delta estradiol that we see in the erratic production in these women.
Absolutely agree. It's the fluctuation that is important for women. And we have learned this very well in women biology because it's always the fluctuation. You may have hot flashes even 10 years before the last menstrual bleeding, during just your premenstrual days or the first day or the second day of the cycle. So I think that stabilizing hormone across the transition is the best way. And we have really to start in premenopause, because if you start really when you are late perimenopause and you still have this, up and down, it's much more difficult because you can have already some kind of pathologies, let's say polyps, let's say fibroids, they grow. Instead, if you start in women 40 plus, 45 plus, this is very good. And I hope that maybe companies producing NK3 receptor antagonists, they will design a study that is not only for postmenopausal women, but that can be also for perimenopausal women. And we can produce safety data that maybe this drug can have a role also during the transition in these women. But it's too early to say that.
So now I'm going to move on to some of the questions that have been raised by the attendees, and we'll see if we can go. There are a lot of them, so maybe we can keep both of us our answers short. Would you routinely check FSH as a predictor for menopause?
FSH to predict menopause. As you know, we have so many apps out there. We have so many algorithms. There is a huge market of all this stuff. But please keep in mind that you may have a patient they were diagnosed with premature ovarian failure, or patient you believe they are menopausal and maybe they can still have a cycle. So we don't have to think about menopause. We really need to think about this period as a whole to try to figure out, of course, until women, they may need a contraception. But the message I want to give it to you, that if you are in doubt, don't do so many hormones that you spend a lot of money. You just go on with your contraception, especially if you're using natural hormones, and that will be extremely good and positive.
My only comment would be that can be very misleading, that there are many women in late perimenopause who, if you look at their FSH, it will look like it's in a menopausal range, but if you look at their estradiol, it's in a premenopausal range. The way I explain this is that the ovary is capable of responding, but it's taking a lot more effort from the pituitary to get it to respond. So measuring FSH by itself is of little value. Do some women have symptoms before they enter the early transition? I think you've already addressed that.
I think so.
This, I think, would be more for Nanette. I have no experience. This says, have you correlated gene activation in lactation with activation in the peri and menopausal transitions? Work out of a Canadian lab.
I don't know nothing about that. I'm so sorry, but I'm sure that we can keep the question and send to Nanette if she has an idea of those more in-depth research questions we are not able to answer.
Is there evidence of hormone replacement therapy improving cardiovascular outcomes in later life for patients?
Sure, there is. We have evidence for premature menopause. They are quite clear, and we have, let's say, less long-term evidence. But what we know, that if we start hormone treatment during the window of opportunity, therefore across the menopause, when women they have hot flashes, we may have benefit on many surrogate markers that can predict future risk. So keep in mind that the best data, as far as I know, they were produced in early or premature menopausal women, in which there is absolutely no doubt a significant prevention in terms of overall mortality and cardiovascular mortality, myocardial infarction, stroke, etc. But also, if you split the data between 50 and 59, when you treat women in that window, you have some benefits. But as you know, guideline of cardiologists or stroke expert, etc., they don't put menopause hormone therapy as primary prevention for cardiovascular endpoints. I'm wrong, Stephen? I don't think so.
Thank you for this wonderful speech. May I ask whether hormone replacement therapy should be considered for women with early menopause who have severe symptoms but also have future risk for breast cancer?
Sure, sure. I mean, remember always that the risk of breast cancer, if you are a 35-year-old lady, if you will have your hormones, you will have a much higher. There is a wonderful manuscript that was published so many years ago by Rogerio Lobo on this, that he showed very clearly, doing statistical speculation, that you have more risk. So please do not consider that risk. Consider that also BRCA mutated patients, so the one at high risk, genetic risk. There is no contraindication to prescribe systemic hormone therapy for breast cancer when you are young, okay? Because you can prevent, for example, ovarian cancer, etc. So do not overemphasize the breast cancer risk in women they enter menopause so early. Propose the treatment. If you are afraid, you can propose even a low dose hormonal contraceptive pill in which we have plenty of data that the breast cancer risk is very low. And, but do not avoid treating women with premature menopause, please.
Actually, in the 2021, the UK registry data on 250,000 women showed that ever users of contraceptive pills had an odds ratio 20% reduction in breast cancer compared to never users. And that's pretty powerful.
No, but there is a lot of confusion sometimes in the literature, depending, and I understand the reason why people are asking, because they are not always everybody on the same line,
It's a complicated question. Can we rule out confounding factors like poor health when we look at escalating or clustered symptoms plus severity in these cohorts? In other words, is robust health going into perimenopause protective, or does it influence the increased risk of poor health outcomes for women with early symptoms and clustered elevated symptoms?
Well, I know, according to the study that has been published, that they correct for some kind of risk factor. Think about socioeconomic background, smoking, alcohol consumption, etc. Because that was a very, very well designed study. However, I'm sure that artificial intelligence for the future that will help us addressing all these questions. The problem is, sorry, I have to drink. The problem is really that there are many different variables, and we have not to think about to be, it's not a panacea. Hormone therapy, remember, it's always for quality of life, but of course, it can have some benefits. But we have to consider a good lifestyle as well. So now, in our guideline, I'd like always to put first line exactly as we put in the toolkit, that an healthy lifestyle is important. So if you correct for healthy and for lifestyle, this is very important. But if we promote an healthy lifestyle, that will be much better for long-term cardiovascular and metabolic risk.
This question is, one of the most frequent symptoms in pre and perimenopausal women are sudden bleeding, sometimes very, very bad. What is your experience?
That's true, my dear friend. This is the reason why sometimes we use IUD, for example, or sometimes we have difficulties and we can bring also the woman to the surgical theater. There is another chapter, I think, that we can open for the future discussion in IMS. Also to include, for example, antagonist of GnRH alone or in combination with some hormone replacement therapy to help some uterus to go throughout the transition. This is a minority of women, but maybe if we are wise and we prepare these women a little bit in advance with this drug that unfortunately they are very expensive, only they are reimbursed in some market for fibroids. We hope for the future, at least in Europe, for endometriosis, etc. But maybe we can play with some of this drug, but we have to produce data, okay? We cannot say that they are useful, but we have to control the bleeding sometimes, even with hysterectomy, our dear friend.
I would add my 2 cents. This is my hobby horse. I think the big divide is the bleeding structural or hormonal? And once you have evaluated that, if you've ruled out structural, if this is dysfunctional anovulatory bleeding, then the best treatment is going to be low-dose birth control pills if it's not contraindicated. Understand that the use of progesterone only will cut down on heavy menstrual bleeding, but doesn't result in a lack of irregular bleeding. Even the drospirenone only pill, which will prevent ovulation, doesn't prevent follicular development. And if you look at the package insert of that, 64% of them had irregular bleeding in cycle 1, 40% even by cycle 13. So I think that to our patients, all the blood that comes out of their vagina is their period. To me, a menses is a bleed preceded 2 weeks before by ovulation. If you don't make progesterone, you don't ovulate. When you bleed and when the functionalis is destabilized depends on how constant the estradiol level stays.
I agree with you, Stephen. You are the expert on the endometrium, I know.
A lot of people in perimenopause, early or late, are being prescribed continuous progesterone. Seems much of this is for the sleep benefit symptomatically, but do we have any evidence this is helpful for heavy periods, reducing hyperplasia? How assertively should we insist on sequential progesterone in perimenopause?
Fortunately, we don't have so many data, my dear friend. So I absolutely agree that natural progesterone is fantastic for the sleep disorder, or at least is better than other. But if you have irregular bleeding, that kind of product, you cannot be really sure that there is nothing in there, and then I really believe that during the transition, we really need to stabilize the bleeding by using some kind of contraceptive combination, and I know, and maybe you can add the natural progesterone if you want alone, but this is really, really a trick I don't want to teach you because, we don't have to overdose hormones either, Remember that we have also sleeping pill. We don't have always to overemphasize too much, Of course, hormones, they can be useful, but in some cases, you have to consider also sleep disorder and sleep disorder expert. They can play with us and help women going throughout the transition. This is my personal feeling.
I think what you're saying makes a lot of sense. If a patient needs a progestational agent and sleep is an issue, often natural progesterone is helpful, but you don't want to use this as a sleep medication. The adding of progestogen of any type to estradiol will increase the risk of breast cancer, some more than others, some less than others. In addition, it upset me, one of the major influencers in the States recently on her Instagram made a comment about how wonderful progesterone is for sleep. And that is true for many people, which is why we prescribe it before bed. But we have other people who feel like a zombie the next day from it, and other people who are any progestogen intolerant in terms of breast tenderness, acne, mood swings. So it is not a panacea. Some people love it and other people do not. So I think you have to, as you finished your talk with, individualization is the key.
Absolutely. Remember, the progestogen is very potent because act as a neurosteroids in the brain. And depending on the enzyme and depending on your neuroendocrine threshold, you can develop a good, you can have a good results or bad results. So please don't generalize this concept because it's really a nonsense from a scientific point of view.
So we have gone slightly over our time limit. I'm going to ask them to put back, there are a couple of slides that I've been asked to talk about. Can we put those slides back up? I really want to thank Professor Nappi, and I want to thank in absentia Professor Santoro. This slide, please visit the IMS website to find out more about the many educational events and resources that you see listed here, and think about becoming a member of the IMS. Next slide. Many of the resources are available for free. There's a free 1-year IMS membership if you complete the Impart Level 1. There are IMS memberships that are available in partnership with your local and regional societies who are members of CAMS, the Council of Affiliated Menopause Societies. And there's monthly live events and extensive library of educational resources that are available as well. And with that, I want to thank Bessons for their unrestricted grant. I want to thank the IMS for making the effort to do this. And I want to thank in person Professor Nappi, and in absentia, Professor Santoro. And until next month, everybody have a good day, whatever time of day it is where you are. Thanks.
Bye. Ciao, Stephen. Ciao, everybody.
Take care.